Good morning, everybody. Day 2, and I'm particularly excited about this session. Maureen Dobbins is a bit of a hero and has been in this game for quite some time. We're lucky to have her here. She is in nursing and a professor at McMaster University. I had the pleasure of spending considerable time in University of Toronto, and McMaster is a special place in Canada. It's pretty much the epicenter of evidence-based medicine with David Sackett, and he's no longer with us, but his legacy lives on. Maureen has, not that citations make a person or anything like that, but she's got over 12,000 of them, half of those in the last 5 years or so. She is really kind of known a lot for knowledge translation and implementation, or whatever we're calling it these days, knowledge mobilization, evidence translation, etc. Has really done some of the seminal work on knowledge brokers and the use of those in clinical practice, and is really at the nexus of decision making in terms of clinical expertise and what to do with evidence. And instead of just imposing evidence on people, really working to integrate it with what we know about them individually. So I'm really looking forward to your talk, and I'm not going to talk anymore because that saves you some time here. Welcome.
Thank you, and good morning. And I would just say the pleasure is all mine to be here. Australia has a special place in my heart, actually, for 2 reasons. My grandfather at 17 got on a boat from London, England, and came to live in Australia in the mid-1920s. And the only reason he went home was when the Depression happened. He couldn't get his visa renewed, so he sadly went home and somehow ended up in Montreal, where I actually was born. And I also lived here, just outside of Sydney in 92, 93. And something happened while I lived here, and I did some work as a public health nurse. I met someone who told me I needed to do a PhD, and here we are. I had never thought of doing a PhD until then. I'm just going to see, I'm not seeing this go forward. Do I have to do something else?
Oh, green button.
I am pressing the green button. Oh.
It is actually showing up on the screen.
Oh, is it? Oh, and okay. Let me go back. Thank you. Thank you. Okay, it wasn't up here. I have been around a long time. So at 57 years old and 30 years this month that I've been thinking about and working on whatever we want to call it. I prefer to use the term evidence-informed decision-making. So I actually feel like a grandmother in this room with many of you, and you know, have even seen people replicating some of my work without actually knowing they're replicating it. It's just that long ago that it was done, and they don't go back that far now to read some of that stuff. You know, I also want to acknowledge where I come from at McMaster University, and also where I live, that is located on the traditional territories of the Mississauga and Haudenosaunee nations that are within the lands protected by the Dish with One Spoon Wampum Agreement, which was really about sharing all of the resources and only taking what you needed. And I think that's, just wanted to share that with you in terms of where we are able to do our work, and are so thankful for being able to work there. You know, Canada's a big country, so I live where that blue dot is. There's a little bit of the US in here as well. And then you saw this already. If I was at home, this is what it should look like right now in my backyard. It didn't quite look like that, so this is from last year. But autumn is a beautiful time to come to Canada. There's really no bugs at that time of year. And just a week and a half ago, I was on the French River canoeing, and there was nobody there, and it was like summer. It was not super hot, but very nice, and no people, and just a beautiful time. So I would invite you to come to my neck of the woods, which is, this is about 5 hours north of Toronto. So what I want to do today, and I know I'll be getting kicked off the stage. I can talk for a long time, but I really want to leave some time for questions. I want to tell you a little bit about my story, which includes now 3 decades of implementation learning. And the title around paddling upriver, I'll talk a little bit about why I think about that and why practice-based implementation, why I think it's time for us to think about that. And I saw some amazing examples yesterday of presentations of using the knowledge we've gained around what we know about factors related to implementation science and actually using it to plan projects, not because it's a funded research study, but because it's work that's going on hand in hand with decision makers. So I'll end with that. And so it's really just a little bit about starting as a public health nurse, and I can use this picture here in 2 different ways. Probably when I started out as a public health nurse, I'm this bigger fish looking a little worried about what do I know about being a public health nurse, even though I felt I had a good undergraduate nursing program. I learned how to critically appraise research as part of my nursing program, and I brought that to practice, but I found it incredibly hard to make time to actually look at the literature, to use that literature, to take the time out of, at that time we were doing a lot of home visiting for first-time moms, and that's what I spent every day doing. And there's a couple of things that have stuck with me since those days in the very early 90s when I was a public health nurse. I had the luxury of working at a health unit that had what were called cross appointees. So some of my professors in my school of nursing, their time was bought out by the health unit to come and work with us in the health unit. And in my particular health unit, it was to model how to use research in our practice. So that was really, really important. Many health units didn't have that, but they modeled it in real time for us. And the other thing that I've carried with me for my entire career is, how can I help the nurse that I was back then, who really was committed to using evidence in my practice, but couldn't find the time to do it? And I was overly confident in my ability to critically appraise that evidence, and I had an amazing librarian that I could call up and say, can you send me articles on X? And they would show up in a big envelope, which also dates me because it was actually hard copy. And they'd sit on my desk for a long time, maybe with one of them starting to be read. And then a month would go by and I wouldn't have read anything else. Then I'd bring them home thinking, well, I'll do this night reading. It didn't happen there either. So everything I've done in my academic career is to really help that nurse. And I've maintained the relationships with public health professionals all across the country, and hopefully even outside of Canada, with that as my guiding light. They are there to tell me what they need, and I'm trying to figure out how to develop or provide them with the things that they need so that they can make the best decisions possible with evidence. And when I think about what I've been trying to do, what my colleagues have been trying to do, Dr. Donna Saliska and Alba DeCenzo started this work long before me, have been incredible mentors my entire career. We've really been focused on trying to change the sector. We're trying to change how public health goes about doing its business of making decisions. So how do we develop the knowledge, skill, capacity, culture at all levels in the organization to use the best available evidence? And I'll show you a slide in a little bit, what I think about evidence. It's not just what's produced in a scientific way, whether it's qualitative or quantitative. So it's a very comprehensive thinking around evidence. But how can we help them make those decisions in a different way so that they bring all of that evidence to bear in their decision making? And then as I finished my PhD, which was in 1999, you know, it was a pretty amazing time in Canada. I would really say a lot of the success that I had was I finished my PhD knowing a tiny little bit about knowledge translation. We didn't use that word yet in Canada at that time, but evidence-informed decision-making, dissemination, knowledge, utilization. There were so many different words. But Canada had just created a new funding organization called the Canadian Institutes of Health Research that for the first time in Canada had a huge emphasis on knowledge translation. And I came along at the time and it seemed like I knew a lot, but I was really just starting to learn. But I did a number of studies in the late 90s, early 2000s, wanting to understand from my public health colleagues, tell me about evidence. Tell me what kinds of evidence. What does that word mean to you when you hear it? What is it? What isn't it? How do you find it? Is some of it more important than other types? How do decisions get made? Walk me through, help me understand at all different levels. And what was really, really interesting about all of that was that people wanted to talk about it. And it takes me to this picture, which is all about trust. And you might say, what does that have to do with trust? Well, this is, some of you may have been here. This is a glacier in New Zealand that I thought sounded like a great idea many decades ago. Except right at the beginning of the walk, we had to walk on this ladder to get over this crevasse that actually was quite scary. And you have someone, your guide, saying, just trust me, look up, look at me, walk across this thing. And what has struck me in my whole career is that public health, when I interacted with them, would say, we trust that you have our best interest at heart. You're not here just trying to build your career as a researcher, getting the studies, getting the grants, getting tenure, as we heard about last night. They really, truly believed that I was 100% committed to making their work better or more effective. And that's why they wanted to work with me, because I was 100% committed to that. And so I think in all of the work that we do, trust between us, researchers, and the decision-making partners, who I fully believe need to be 100% equal partners with us, equal power in all of the work that we do, that's when we have some real magic happening in terms of knowledge translation. We jump forward a few years, and I think this is one of the studies that I'm known for, and I hear many times people have read this. So after a few studies, I thought I knew it all. We're ready for the trial. And I think we heard the word yesterday, failure. We were not ready to do this trial. But thank goodness someone funded it, because what we learned from all the mistakes that were made really set up all the work that we've done since. And 2 papers were published from this, but one that really was, here's the results of the randomized control trial. But we also published, what is this knowledge broker doing? And that's the paper that actually I think's been cited and downloaded more than any other paper, where we were talking about what does this knowledge broker do. And so what did I learn from the knowledge broker trial? Well, I didn't know as much as I thought I did. I thought it was pretty clear how we could measure things and how things would happen. I had this great relationship with all the public health folks that were happy to be involved, but there were a whole bunch of things that I didn't know. And one of the things, if you've read the paper, that I came out and said, I think this paper in 2009, was that I didn't think randomized control trials were the way to evaluate knowledge translation interventions. And I, for the most part, have not done another randomized control trial. Only 1 or 2 others that were comparing something like a tailored message to a different type of message for a different purpose. But when you're trying to change an organization, I think it's impossible to randomly allocate your groups. And you need to do so much tailored work with them. You have an N of 1, like every organization is getting a different intervention. And so I was committed to studying this using case studies moving forward. And a couple of things that I also learned back then, so we're talking early 2000s, there was a lot going on in Canada, but we had a little bit of this going on, which was, if we just keep our heads down and keep quiet, like she'll go away and all of this will go past, right? Like just, it will go back to the way we used to do things, right? This will pass just like all the other things. So there was a bit of that definitely going on. And the other thing that became clear to me is this is my outcome. It was pretty fuzzy. I thought I knew what it was, but I wasn't really sure how we would actually find it. And that failure, like sinking feeling only a few months into the grant, when we knew we weren't going to be able to measure some of the outcomes. Our outcome measure was not precise enough to pick up some of the things we were already hearing. So that was really discouraging, but also really made us think, yep, it's back to the drawing board. We really need to work on this. And so this is long before CFER existed and long before we had the luxury of those types of outcomes and the tools that exist now. A few other things. I didn't know what I didn't know about this, but also public health didn't know what they didn't know. So many of you have probably experienced this before. Everyone thinks they actually are already doing knowledge translation or evidence-informed decision-making. So if, I know, show of hands, have you ever said, well, this isn't new. We've been doing this for a long time. What are you talking about? So this public health was definitely like that. And how could you get them to think about evidence-informed decision-making in another way? They actually need to really engage and learn to realize the light would go on. Oh, now I know what I didn't know, but they didn't know it before. So that was important. Time, of course, we're always going to have that problem. In public health, there's never a lack of things to do, so there's competing priorities. And we heard many times from Andy yesterday about leadership engagement. And true leadership engagement is really important, not just the lip service. Yes, we're going to be involved, but not doing anything to really support it. And what I was starting to see in this trial was that we had 34 organizations in the knowledge broker intervention arm, and all of them were doing this EIDM thing in a slightly different way. So that was the first time I started to get that inkling. And slow progress. We barely moved the needle after 12 months of an intervention. So learned, going forward, this is something that takes years. And I think we heard yesterday, maybe 7 years might be how long it takes to implement. So that was that first study. And a few things from the practice perspective, I was learning then, we're not talking about changing just individuals. We need to change the whole organization. So why are we not looking at the organizational change literature, of which there's thousands of articles out there? Senior management support was really, really important. An internal champion who's in that public health unit, who's your raw person, who's really trying to encourage people, and communicating what is happening. From a research perspective, I learned flexibility. And as researchers, we don't really like that word that much, particularly if you're on the quantitative side and you like your RCTs, which I always used to. I thought you needed to have flexibility. You needed to engage with the decision maker long before you wrote one sentence for that grant, and work in partnership and work on their goals. I think someone mentioned it yesterday, and this happened to me as well. New into my faculty position, I was that KT person, one of the KT people at McMaster that someone would come to and say, oh, can you write that paragraph about the knowledge translation plan for this grant? And it was never a very good experience for them, because what I would usually say is, well, you should have talked to me 3 years ago before you actually, because I would have said, well, you now need to go to your decision maker and you need to listen to what they need and want and build those relationships if you don't already have them. So I'm sorry, I can't help you. And I was not really all that interested in helping them write. I'm going to go to some conferences, I'm going to publish some papers, right? It needed to be something more than that. We jump forward now a few more years to what we refer to as the FISI study. This is the Partnership for Health System Improvement Grant. And this was an amazing competition that was funded, an amazing funding stream we had in Canada for a number of years. In order to be eligible to apply for this grant, you needed a decision-making PI, so a decision maker. I had 3 medical officers of health from 3 different health units who partnered with me as co-primary investigators, equal power. They also had to put up 30% of the cost of doing the research, which at first I was really angry about because I thought they don't have that money to spend, so I'll never be able to apply. But actually, when it was important enough to them, they had the money. And when they've had that amount of investment, then they were really engaged in getting what they wanted out of the grant. I put up here, I don't know if anyone's noticed, when I wrote this grant, I found this site in Australia that provided me with a definition that spoke to me about what do I want my knowledge broker to do. They're a human force behind knowledge exchange and adoption. They bring people together, they build links, they identify gaps, share ideas, and I love the bolded part. It allows information to be used to solve a problem or lead to a better way of doing things. Sadly, I went to the link this morning or last night, and it's not still a functioning link, but you had that right here, and this would have been probably, I wrote this grant around 2004 or 2005. And what did I learn about this? So this was a case study, 3-year study. We worked hand in hand with 3 public health units who basically developed the knowledge broker intervention with me, and we tailored it to what each organization wanted. Not the best picture here, but this is Kilimanjaro. And why this is here is what I learned in this grant is that there's no 2 organizations do EIDM the same way. Every organization I've worked with one-on-one has to struggle to find their own unique way within their organization that this makes sense for them. And they all do it differently, every single one that I've worked with. And that's like, there's multiple ways to get to the summit of Kilimanjaro. And that's what we need to be open about, is that it is very tailored. And that's why I struggle with the ideas of the randomized control trials that continue to study so many things related to implementation science. It's so, we have to, I believe, we have to really, really tailor it to what each one it needs in order to move it forward. So some things that we learned, keys to success, is it really is grounded in organizational change. And if anyone has read any of that literature, there's no lack of models, frameworks. The challenge there is many times they actually are paywalled and you can't access them without paying for them. But it really is organizational change that we're talking about here. It really is key to have the leadership on board and actively participating and modeling the behavior, setting strategic directions. The health units that have made the biggest progress in implementing evidence-informed decision-making have actually identified EIDM, that's what I call it, as one of their 3, 4, 5 strategic priorities. That isn't something we're doing with some extra money that we have left over at the end of the year, but actually maybe a 5 or 10-year plan in order to make it happen. The shared vision is with me and them working together to achieve what their goals were. This is a moot point now, but it was really important back then. We did face-to-face and virtual contact. Now we can do a lot more virtual, but this is actually quite a while, long before things like Zoom existed. We did organizational assessments, both at the individual level and at the organizational level with the senior management team so they could identify their goals, and then tailored that intervention. So we created a blueprint for the intervention, but then each organization took it and made it make sense for them, which meant I needed to be flexible enough in my research design that we were going to be able to study it in the way that they wanted. And practice-based and relevant. So often it's the off the side of the desk. It's this extra thing that we need to do. And what we would say is, what's a decision that you need to make in the next 6 to 12 months that you're grappling with? Let's work on that. Let's go look at the evidence and see what it says, and then think about how we might be able to use it and work with them hand in hand as we walk through that. we needed to work with multiple levels at the same time. So when we first did this study, we were mostly working, senior leadership was on board, and then some frontline folks were identified to be the ones to work on this. And the managers got left out of the whole process. Another big failure, mistake. You have to have the managers, you have to have the directors, because if they aren't on board or understand what their staff are doing, then they won't support them. Starting where folks are at. So I always say they knew a lot more than they thought they did. So let's find that out and let's see that as a win and build on it. Give them lots of opportunities to practice new skills. So just like anything we learn as adults, you got to do it over and over and over again before it starts to be in there. I've done critical appraisal so much now, I don't think it'll ever leave, right? It takes a lot of practice. And again, that flexibility, sometimes face-to-face, sometimes virtual. We did a lot of site visits. So once a month I went around, sat with the medical officers of health, sat with their teams. How's it going? What do we need to think about? What's not working? Let's tweak it. And the 3 health units where we had a knowledge broker embedded, the knowledge broker was there different amounts of time depending on what the health unit wanted. Now we jump forward a little bit, and in 2011 I became the scientific director of the National Collaborating Center for Methods and Tools. It already existed before I took it over. It actually came into being around 2007. There's 6 of these centers across Canada, and they exist from the first time that SARS came to Canada. And the many inquiries that happened in 2004, 2005 following SARS-1 was that our public health system was not at all prepared for, at that point, which was an epidemic. And so they created a couple of things. The Public Health Agency of Canada and the Public Health Agency of Canada created us. Many other things were created. We were the only 2 things still standing when this pandemic happened. And so we do a lot of things. We try to curate the evidence on what works. We have spent years developing resources to help public health develop the skills and the culture to use evidence. And we're trying to advance public health to use that evidence to improve the lives of everyone who lives in Canada. And we've heard that type of wording throughout the province, and throughout the conference. And I just want to draw your attention to the 5 bubbles. This is our model. And this model really quite simply illustrates there's multiple forms of evidence that inform our decision-making in my area, in public health. Research is just one of those. And this model really speaks to me, and it speaks to public health because it allows them to say, here's evidence, here's research evidence, but depending on what's going on in your jurisdiction and depending on what's going on with community and political will and resources, you might make quite different decisions depending on where you live in Canada. And you saw the map. We're a massive country, and that makes sense. That something that might work in a large urban city like Toronto isn't going to work in a small urban center, or very much won't work in Indigenous communities. And so this model allows us to have that flexibility to tailor. We've continued to evaluate the Knowledge Broker program, and we've collected both quantitative and qualitative data on continuing to offer this program to health units all over Ontario. And some of the things we've learned is it doesn't matter how big the health unit is, where it's located. If we used to think that if they were close to a university, they were more likely to use evidence. But we also know that there's some really positive effects that are coming out of that. So I'm just going to wrap up with a few final slides here. The rapid review, we recently did a rapid review on, we were asked to do this by the British Columbia Ministry of Health. And they wanted to know what types of strategies are effective in supporting evidence-informed decision-making. So we found 59 studies. And there's some, we looked at both evidence-informed decision-making at a organizational level, or we have an evidence-informed practice that we're trying to get implemented. they've used a lot of similar strategies, including specialized roles within the organization that drive implementation, education, training, developing the processes that make the behavior happen, so that you have to work in that way, as well as leadership. And we mapped this to the COM-B, which Nick showed this yesterday in his frameworks talk, and aligned. We didn't go into this thinking that this would align with the COM-B, but when we really started thinking about what we were seeing, we certainly saw that it mapped really, really well. Interestingly, I just got a rejection from Implementation Science saying that this paper doesn't fit what their goal is, so we'll be looking for somewhere else to publish it. All to lead to, after all of this time of working with public health and being there to support them, they turned to us during COVID. So I run a center, this center, the National Collaborating Center, and they turned to us and said, please help. We can't keep up with all the evidence, help us. And so since May 2020, we've now completed, it's actually now 95 rapid reviews, we just completed 3 more, at the request of public health professionals at all levels across our whole country, and a few outside with the WHO. That comes when you develop years of relationship building with those decision makers. Why upriver? Just give me a few more minutes here. So why am I talking about upriver? So those of you that do this work know that it's long, slow, really, really, really hard. So when my daughter signed up for a 50-day canoe trip in the Yukon a few years ago, who would have thought they would spend half of that time dragging their boats upriver instead of having fun canoeing on them? And, this strikes me as having a lot of similarities to what we do when we are starting our work of working with organizations. It really is like pulling these really heavy canoes. It's hard, slow work. It's also really hot, and there's lots of bugs. You can't see them. And you go to here, and it's like, well, that doesn't look so bad, except that they had to go past those mountains. Right? So they're going a long way, and that's what it feels like. So 50 days, they covered 728 kilometers. In 28 days, they only covered 135, and then they did 600 in the last 22 days. It was really hard. I mean, you couldn't give up because there was nowhere to go. You had to keep going. But it was tough, and then all of a sudden, you're going downriver, and this happens too. All of a sudden, we pick up speed, and we might not be ready for how fast our organizations now want to get going. And you can see here now they're going downriver, hitting some pretty big white water, and you need to be ready for that. But it does look pretty fun in the end. Last couple slides, the practice-based implementation. So I did a little looking. I asked one of my staff to do a quick and dirty search in Medline a few weeks ago. And I'm just showing you here so that you see that it was a fairly involved search. And we identified about 1,430, this is just in Medline, 1,438 titles that were reviews and had something to do with knowledge translation or evidence-based practice. We looked at about the first 200, and the reason why I'm showing you this is in the first only 200 of those, there's 15 or 16 reviews here of all sorts of different things. I think if we had searched through the 1,400, we probably would have well over 100, I'm sure. Maybe 200, maybe 300. The systematic reviews and any other type of review that's been done is now becoming a barrier to being able to see what's in the literature. There's just so much there. And are we really using the knowledge that we have? So I just want us to think about that. And then we did an environmental scan where we also were looking to see what types of websites are out there that provide resources. Sorry, let me just go back here for a moment. And one of the things that we found, it wasn't exhaustive, so I know there's many more, but we found 104 websites around the world, and a great many of those are cataloging those wonderful 159 models, theories, frameworks that Nick was talking about yesterday. There's not just that one site in the US, there's all sorts of sites that are putting all of those there, which can make it then very, very hard to know where to find the information. And so 2 slides, or sorry, 3. This one I used years ago at the Cochrane, at a closing plenary for the Cochrane collaboration, and I was respectfully telling the Cochranites, those reviews that you work so hard on doing is just the tip of the iceberg. The real work is putting that evidence into practice, is the part of that iceberg that's underneath. Now I will challenge you with a different kind of message. The implementation science that we are working on, I think is the tip of the iceberg, and that really, really, really hard work that we have to do, rolling up our sleeves to work with our decision makers to actually get that evidence-based practice into practice, is all that work, is that part that's below the water. This is a different trip. My son then did the 50-day canoe trip last summer. This was their route, only they had 3-4 other potential routes if things didn't go right. So I can't really show you here. This was if everything went well, they didn't get too many windy days, various things that could happen, then this is what they would do. But if they were late and they were not going to be able to get to that red dot when they needed to, they had all these other routes that they could take to save time. And they needed to make those decisions on the fly. They couldn't always, they're very remote, so they can have very little interaction back at camp, thousands of miles away. They needed to look at what was going on, just like in the rapids. I showed you back here. This one, we can study these rapids for hours, and we do, before we do them. Not me, I don't do this. They study them, but 100 different things can happen when you're actually doing that rapid, and you need to think on the fly, what are we going to do if this happens? What are we going to do if this happens? All these different scenarios, and that's what I think our work in implementation is. So I will end there with this final slide. This is my backyard last week before I came. Would love to continue this conversation with you with a glass of wine and a fire if you were to come and visit me in Canada. Thank you.
Thank you very much, Maureen. Normally, I'm a little agitated when presenters get to the point where we're getting into question time, but I figured another picture of the Canadian wilderness and what it takes to get through there is worth way many questions. We do have a couple of minutes for questions, though, so I'm going to throw out to the audience. We've got Robin and at least one other person, so if anybody has a question. Yes, out in the back.
Hello, thank you very much. Fantastic. I'm picking up a bit on your point about implementation science being the tip of the iceberg. One of the sometimes often unstated, although we need to look at our language sometimes, I think, which is about, in a sense, transferring insights and knowledge from the academy, from research, from wherever, into practice. And I think it's a much more complex process. For me, it's an exchange between, it's not just one way, it's practice to theory, to research and backwards and forwards, which comes into co-design and all of that. And I'm wondering what you think about that, because I think there is a very persistent mindset that's often unstated, where it's a transfer from the experts to practitioners.
Absolutely, I agree with you 100%. It's a dialogue, and we need to absolutely co-develop. Part of what I was trying to get at is we can do as many studies to thinking we will understand absolutely every single piece of the process of implementation. But when you actually start working with whoever the decision maker is and the clients that they serve or the patients, you can't, it's not cookie cutter, you can't study absolutely everything. It will be different in different circumstances, and we need to understand so that we can be flexible to figure out with our partners how to use that information. Thank you for your question.
Thank you. We do have one online question. Linda Hayes asks, in my experience, knowledge translation, mobilization responsibilities often fall to junior members of staff who may have little access to busy senior management. Any tips on how junior staff can encourage leadership to engage with this work? And thanks for a great session.
And that's a great question, very good question. And so, you know, one of the, I guess my first thought on that is thinking about who's influential in the organization at different levels and maybe forging some relationships. So it can be really intimidating to think I have to, you know, I need to bring this idea to the medical officer of health, and I'm, you know, a frontline nurse just hired, maybe a new grad. But I think thinking of intermediate steps of, is there a manager or is there someone else in the organization that you could share those ideas with, and then have others bring those ideas forward as a start.
The voice of experience. And Nikki, you want to go next?
Hi, Maureen. Thank you for a fantastic session. I was interested in your commitment to methodology. So saying, really, I think case studies are the way that I found I need to go. Could you elaborate a little on what you're doing with the case studies? So I assume you might be using mixed methods, or how have you managed this? It's something we all grapple with.
Yes, so one of those studies was that. It was very much, we collected both quantitative data on some measures around changes in knowledge, changes in intention, but then we also had a very robust qualitative component where we spoke to people throughout the project. We conducted interviews, focus groups, and really used, what I've learned is the qualitative data is where the real knowledge is in terms of what's happening. That's the rich data where you can really see how has this impacted a public health decision maker's thinking about this, that you won't capture in a survey or some type of a assessment tool. So those two things went very much hand in hand. And the other thing that we added, another component, was a social network analysis. So I had an amazing graduate student work with me who was an expert in social network analysis, and we were able to map relationships that really helped understand how things were working in these three very different health departments and who spoke to whom and who didn't speak to whom. And that was really important as well. And that helped us as well in our thinking about the next version of that intervention.
I think that's all we have time for.
Thank you so much.
That's great. Thank you.